Good afternoon, folks. Give me a couple seconds to set up for the show, and I'll be right with you, please. Okay, now today's A. We're discussing. Give me a minute, I'll tell you. A nursing home can profit even when the care fails. Okay, so that's what we're discussing today for A. Please join me in today's discussion. Here we go. Chair members of the committee, thank you for the opportunity to speak. I want to begin in a place many of you have seen. In a nursing home hallway, a man sits in a wheelchair, waiting. Waiting. A nurse rushes past, carrying more responsibility than any human should. A daughter stands in the doorway, holding her mother's sweater, wondering how the system built for care could forget someone so loved. These are not isolated stories. They are symptoms of a system whose incentives you have incentivizes you have the power to change, because today a nursing home can profit even when the care fails, and the economic structure of long-term care makes that not only possible but predictable. The incentive structure driving harm. Our long-term care payment architecture pays for occupancy, not care. Medicaid reimburses per resident per day. Medicare pays even more for short stay rehab. Neither payer asks. Whether the resident was turned, fed, hydrated, or safe. This is the policy framework you inherited, and the one you now have the responsibility to fix. The evidence is clear. 54% of the US nursing homes are understaffed. And the data comes from 2024. Facilities with the lowest staffing levels have nearly triple the rate of serious deficiencies. GAO 2023, private equity owned nursing homes have 10% higher mortality, more hospitalizations, and fewer staffing. Health Services Research 2022. CMS found 1 in 4 nursing homes had infection control deficiencies even before COVID-19. These failures are not random. They are predictable outcomes of the incentives we have allowed to stand. Economic modeling, how profit is extracted even as care declines. To understand why care falls or fails, we must understand the economics. Labor is 60 to 70% of operating costs. Cutting staffing is the fastest way to increase margin. If a facility reduces CNA hours by 20%, it can save hundreds of thousands of dollars annually, even as resident harm increases. Related party transactions shift profit off the books. A 2023 HHS OIG report found that over 70% of nursing homes use related party transactions. Economic modeling shows a facility may pay one to 3 million annually in rent or real estate company owned by the same investors. It may pay hundreds of thousands in management fees to another related entity. The operating company may appear to lose money while the ownership entities profits. The structure allows owners to extract profit even when care collapses. Understaffing is financially rational under current incentives. Let's model a typical 120-bed facility. Cutting RN staffing by 0.2 hours per resident per day saves $500,000 annually. Cutting CNA staffing by 0.5 hours per resident per day saves $700,000 annually. Combined, the facility can increase margin by $1.2 million with no penalty tied to care quality. Under the current policy, neglect is profitable. Poor care increases hospitalizations, which increase Medicare revenue. Residents in low-staffed facilities are 70% more likely to be hospitalized for preventable conditions. Each hospitalization generates Medicare Part A payments. Potential skilled nursing facility NSF SNF readmission, high, high acuity reimbursement. In other words, the system financially rewards the consequences of poor care. The cost of failure is externalized to hospitals, families, and taxpayers. Economic modeling shows preventable hospitalizations cost Medicare billions annually. Pressure ulcers cost the system 3.3 billion per year. AHRQ falls cost 50 billion annually across Medicare, Medicaid, CDC. Nursing homes save money by understaffing. Everyone else pays for the fallout. The human cost of legislative interaction. These failures are not abstract. They are happening in your districts. Residents in low-staffed facilities are twice as likely to develop pressure ulcers. Falls resulting in injury are significantly higher in chronically understaffed homes. Infection-related hospitalizations rise sharply when RN staffing drop below 0.75 hours per resident per day. As legislators, you are not bystanders. You are the stewards of public dollars and of the people they are meant to protect. Policy reforms that cannot wait. If we want a system where care is the incentive, not the exception, we must change what we pay for. Minimum staffing standards. CMS evidence shows that RN staffing below 0.75 per resident per day sharply increases mortality without enforceable minimums. Every other reform is cosmetic. Ownership, transparency. If a nursing home pays rent to a shell company owned by the same investors, lawmakers should know, taxpayers should know, families should know. Quality linked reimbursement. Hospitals are paid for outcomes. Nursing homes should be too. Rewards. Reward safety. Penalties. Penalize harm. Real penalties for chronic failure. GAO found that half of facilities with repeated serious violations face no meaningful enforcement action. If a facility repeatedly harms residents, it should face escalating consequences, including temporary receivership, workforce investment, loan forgiveness, uh, apprenticeships, career ladders, retention raises when pride rises. These reforms are not radical, they are overdue. The moral and fiscal imperative. Legislators often ask, what will this cost? The better question is, what is the cost of doing nothing? What is the cost of another preventable death? Another daughter holding her mother's sweater. Another nurse crying in her car after a shift she never should have been asked to work. Another hospitalization that could have been prevented with adequate staffing. A nursing home should not be able to profit from neglect. A resident's suffering should never be a revenue stream. And the dignity of older adults must not depend on whether a balance sheet can be optimized. If you have you have the power to change this. You have the authority to rewrite the incentives. You have the responsibility to act. The hallway is waiting. The residents are waiting. The families are waiting. Please do not make them wait any longer. Okay, guys, that is A for you. I will be back on with B shortly. Give me a little bit for a break, please. And I will have show B shortly. For now, Gator Wellness. Take care, folks.